out to that again.
So this is the Hema T. The pamphlet that you have is called Hema Shock. We'll talk about the differences in the two. But the basis of this is that it's an auto transfusion tourniquet. So it does exactly what it says. Application is very, very simple. You just take the donut, you place it on your fingertips, and notice I'm going to leave my watch on. That's intentional. And you just grab the strap and deploy. So this is how fast deployment is, whether it's upper or lower extremity. This device is rated for adult upper and adult lower, and can go as small as 30 centimeters, which for sizability, that's about the size of a 10-year-old child. So what's really cool about this is you have visual proof immediately that it worked.
Wow.
So I
See how
took
much wider it is.
95% of the blood out of my arm, shifted it and shunted it to core perfusion. This is your arterial block and your venous block. So what's really important about this is if we have shifted all of the blood out of the arm, we don't have oxygenated blood to continue through certain cycles. We're not having the increased risk of lactic acid production. We're also not having the increased risk of blood being trapped and pulled in microemboli formation in this extremity when the tourniquet is released. It is 2 hours rated on use, so same protocol as normal. This is designed, like I said, for upper and lower, and this can fit as large as an 85 centimeter thigh. So perspective-wise, that's your 45, 50 BMIs. Pretty big thigh. We also have our Hema Shock, which goes 5 centimeters larger, and so that is our tourniquet that's more designed for cardiac arrest. Now, this can be used in that instance on adult upper and adult lower. This was just designed for hemorrhage control. So when we start talking about hemorrhage control, that's exactly what we think of for a tourniquet. But we have to shift our brain just a little bit for this type of tourniquet, because it also applies to instability. So a patient does not have to be flatlined, they just have to be unstable. So what that looks like is a patient that is systolic below 80. The reason why we care about systolic and we don't immediately start talking about MAP is if our systolic is low, we know our MAP is low. That's our divisional factor. And so if you don't have a systolic above 80, it doesn't really matter what you're dividing it by. You're not getting a 60 MAP, which is our minimum for perfusion for the heart and the brain. So when systolic is below 80, we're going to take this and apply it up one leg. Applying it to one leg shifts 500 mils of blood to core perfusion. That is very important when we're talking about the systolic and the MAP, because as you shift that blood, it gives you an increase in that systolic blood pressure to get that MAP above 60 so that we have proper perfusion. Now, in the event that they're completely flatlined, we're immediately going to throw it up both legs. On the 80 blood pressure, if we throw it up 1 or less than 80, if we throw it up 1 and we're still really not where we want to be, closer to 100 and over, we're going to throw it up the second leg. They don't have to be flatlined to utilize both legs. So we're going to throw that up both legs. That shifts and shunts 1 liter of blood to core perfusion. So the significance of that is whenever you are doing CPR, if you don't have proper pre-filling and preload, you also don't have proper diastole filling. The only time that the coronary arteries are perfused in the heart is in diastole. So if our coronary arteries are not perfused, we're also not perfusing into our nominate artery and our cephalic artery as well. So that's where we're getting our cardiovascular ischemia injuries, and we're also getting anoxic brain injuries. So in doing that shift, we are able to get those significant preloads and diastole fillings. Same thing, it's rated for 2 hours. Now, removal is the key. That's what makes this very different than any device that we have seen in the past. It is designed to be titrated down. With our studies and everything that we have seen where we're achieving ROSC in 1 to 5 minutes from complete flat lines. So we're applying, we're starting CPR, we're doing all of our normal steps, and usually we're achieving ROSC within 1 to 5 minutes. So once we achieve that and we see that we're stable, what we're then going to do is start with one leg, it doesn't matter which, and we're actually going to slowly titrate it down. So we're just going to shift and roll it a quarter of the way. That's going to allow us to get about 100 mils of blood to shift and allow the patient to maintain their stability without a rapid bulimic shift. So we talked about the former technology that we've all been a little bit more familiar with. The problem with that was they would go in and the ED has to do a head-to-toe assessment. So the first thing they did was cut those off. Well, when they cut it off, it was pneumatic, so it's a floodgate. There is no slow release. It was a rapid auto shift, again, of the blood, and so that rapid volemic shift caused them to tank and go back into cardiac arrest or flatline from whatever mechanism that they were flatlined from begin with, but now this is because they have no blood volume. So this is designed to be titrated down. You titrate it down, wait 5 minutes, assess, make sure that stability is maintained, and then you go another segment down. And you repeat that until it's removed. The beauty of this that was very different than the former technology is that in the event that you say get down to the ankle before we fully remove it, or say we've taken it off and all of a sudden we start to decline, you can reapply that and you get the same result as you did the first time, and it is made to be redeployed. We also have our pediatric application. So it's your time to shine, sister.
Yeah, I've been recording for Daddy. Come on. Come on, you're fine. Go. Go.
So,
I'm gonna show you how to put it on.
They also, correct me if I'm wrong, they use this in surgery as well. Is that kind of where it came from?
we do have a sterile version of this, and it is based off of the science that has been used in the surgery world and the orthopedics world for total joints, which is exsanguinating a limb
Right.
and applying a pneumatic tourniquet. We have gone, like I said, just a step further, and this is our pre-hospital, but it is very, very similar to our design that is sterile and in-hospital as well.
Right. Okay.
Okay. She's gonna show you how to do it. So this is our pediatric application. You ready?
We just need an arm, sis.
Here, hold your arm out.
Do you want to put it on me first? It's really cool. Yeah, good. Okay.
Put it on your buddy. Can you put it on your buddy first, and then maybe you?
How you're gonna put this on me is you're just gonna grab these straps and pull really hard. Okay? Can you do that? 2 hands. Grab really hard. Pull, pull, pull. Push. Oh my goodness! Look how strong you are.
Good
Can you
job.
grab right here? Grab really close to the ring, and then you're gonna pull again. Pull again. Oh my goodness! Look how strong you are.
Good job.
So you can see, she's never seen this before, how easy it is for her to get it on. So in the event that, you know, she's standing and or I'm laying on the ground and you're saying how for her to put it on. And you see my hand? So there's my color difference in my hand. And that was with her applying it very, very slowly. So it's very easy for a kiddo to put on. Now our pediatric one, you want to try it? Okay. So our pediatric one is a little bit tighter. You're going to notice her face. She's going to wide eye it because it's going to feel weird. And it is tight.
Feel weird.
Okay. So this is going to feel like I'm going like this the whole way up your arm. Okay. Can you fingers this way for me? Okay. Ready? Big hug. Is it so silly? See your hand. Can you show me your hands? Does it hurt? It's a little tight. Does it feel weird? Yeah. Okay, let's stick it out. So you can see, I'm gonna roll it down, okay? Good job.
See, it's tickling.
Little roll. Good job. You did awesome. Good job, Lillian. So you can see how small her arm is. It's about a 24 to 25 centimeter arm. This is intended to go even a few years younger than her, and she's 6.
Wow.
So application is not simple, and for kiddos, the biggest part is that it's not painful. You can see she goes through it, even being nervous, never having felt this before. I can tell you, I put this on my kids, and the first thing they did, they were like, "What is this? What are you doing?" And they get apprehensive because they don't know. But as soon as they feel that it doesn't hurt, then they're willing to be like, "Oh, I'm okay." But when you put a cap tourniquet on, one, there's not one that's going to go her size. Any ratcheting or twisting tourniquet that has that cuff in there, they don't go to her size. But then furthermore than that, they're very painful. So having her apply even a wineless cap tourniquet, you guys know the time difference that takes and how hard it is for a kiddo to put that on, maybe their parent or something in the situation that we did today. Any questions?
So I had a guy earlier, one of the guys. He said, how does this differ from mass pants?
Okay, so with the mesh trousers, it was pneumatic. Those were actually designed to be vasoconstricting. This is intended, and based on the scientific design of it, the formula that went into the circumference and the length of the leg and the stockinette that's inside of it, this truly exsanguinates the limb. It is non-pneumatic, so what that means is we also don't have that floodgate that we talked about. This
Right.
is designed to be titrated down, whereas with mesh trousers, as soon as you deflated it, it was the rapid volemic shift, and there was nothing you could do to stop it.
Okay.
So this is each leg individually.
Nice.
Okay, and then it says, why not cut clothing before placement?
Because it's unnecessary.
It's
So
unnecessary, okay.
it's time. When you are already racing against the clock, we don't need to cut the clothing. Now, say you have an injury, a bullet hole, something we know is going through. What you can do is you can apply this. It's up, your tourniquet's up, here's your junctional point, you have stopped the bleeding, you've exsanguinated the limb. Now, take your trauma shears and cut and expose. But the first thing that we always want to do is stop the bleeding. So assuming that we've got that achieved, now we have time to cut the pants off. And because the profile of this is so small, we also have this space to do so. Now, in the event that we did have those on, the lower extremity, I know a lot of times when we talk about needing to get some fluids in, somebody that's hypovolemic, just dehydrated, multiple factors, starting lines are very hard, so we go straight to IOs. Usually we go to a tibial IO. In this instance, whenever we're applying this to leg, we're going to go straight to humeral IOs.
Okay. The next question was, should these be used instead of a cat tourniquet, or should a cat tourniquet be placed after the Hema Shock?
So no CAPS tourniquet after. I will say, we don't necessarily want to completely remove and replace CAPS tourniquets because this is an answer, not the answer. There's always going to be Murphy's Law and situational incidences that come up where we may not be able to get this tourniquet on somebody, right? Say we have an impalement, a through and through the leg, somebody's impinged in a car.
Yeah.
Well, I can't reach their foot, neither can you. Maybe they can, maybe, but if we have an impalement, we can't do that. So this would be an instance where you would still go ahead and have them put that CAPS tourniquet on until we can extract them from whatever mechanism they're in. Then, especially if it's an impalement, what we're going to want to do is prep ourselves to remove the impalement and then send the tourniquet on. We are able to do that in the field because of the mechanism that this works at. It's going to shift and shunt all of that out of the extremity. Our goal is still always like with the CAPS tourniquet. We still want tourniquet conversion. Now, obviously, if it's a full impalement, we're not getting tourniquet conversion. But this would be an instance where you would actually hopefully get them out soon enough that the CAPS tourniquet was not on long enough to have any of the blood sitting, cooling, and pitting and clotting, so that we can then place on the Hema Shock or the Hema T and shift that blood without those risk factors that we already have with a CAPS tourniquet.
Any other questions? That was all he had.
Great questions. What are the chances of the hospital not knowing what it is and taking it off?
So we send you guys with the how-tos, and this would be where you guys say, hey, it even says remove slowly, where you tell them what it is, but that also comes into play with my job. As you all start using these and implementing these, it is my job then to make sure that the hospitals are aware of what's going to start coming to them. I start working with hospital administration, the emergency medicine physicians, so that they're aware of what this is and how to maintain it, or how to remove it and how to treat with it.
Do you know if the Tulsa hospitals are aware of it?
Surgically, in the surgery departments, they're all very aware of
In
it.
the ED?
We are working on getting into the emergency departments.
Okay.
It's just our normal bureaucracy game.
Right.
Part of what actually helps us get in there is just providing them with education that, hey, your departments are about to be running to you with this. We just need to make sure you know how to manage it.
Right. Any local hospitals at all around here?
We have been submitted at Hillcrest, OSU, St. John's, St. Francis South, Hillcrest South, Hospital in Guthrie, OU, all of the hospitals in OKC, with the exception of a few. So we have started that process. We have started working with Oklahoma Medical Directors Board to get that traction and movement so that we can be very widespread and diffuse and have this almost be a collaborative.
Okay. How long has you guys been using these for?
So the non-sterile version, or I'm sorry, the sterile version of this has been used for 22 years, almost 23 now. We've done 2.3 million cases worldwide to date in over 51 countries. So now the pre-hospital, we have been doing this, I believe, since 2017. This was designed in Israel after some of the first incidences started occurring there. And our physician, Dr. Noam Gabrielius, who created, designed, and patented this, he is a Israeli physician as well as a U.S. emergency medicine physician. So he is now retired. He's also a professor and a very well-published physician and professor. He has multiple peer-reviewed studies that are not only published on this, but multiple subjects across emergency medicine and pulmonary function. Yeah, our studies, all the studies that we have out, which is, numerous. I can send you pages.
You have a lot of them on your website too.
Yeah, tons are on the website. I have an entire book of studies. So this is just my most recent, or the ones that I put in here. Not I did, but my team collected. And this is specifically like auto transfusion during CPR drills. Something to note specifically about the tourniquet itself is that it is set at an external circumferential pressure of 155 millimeters of mercury. So it also acts as a pressure valve. So in the event that we have that patient that we get in their pulse is steady, systolic is below 80, and we apply this, say their blood pressure, ROSC is achieved, and now maybe they're kind of bouncing the other direction. This works as a pressure valve. So in the event that their blood pressure systolic reached above 155, it's going to allow the bleeding to trickle through, which is a beneficial sign for us, because in the event that we don't have maybe devices to measure pressure, this will be able to tell us that, hey, maybe we're moving in a more positive direction. We can start removing this, assuming obviously that it's not for a penetrating injury. But if it is for a penetrating injury, that also gives us indication that tourniquet conversion may be very achievable and sustainable.
Yes. Like your IV, like if you start IV in the left AC, you just obviously wouldn't put it in the left arm.
Yeah, if I had an injury to this arm, you're not going to utilize that arm anyways for our IV access. So that just kind of follows your natural protocol. If the injury is on this side, you're not going to use this side. If we are utilizing it for getting increased stability, so blood pressure or
like cardiac arrest,
we're always applying it to the legs.
Legs
Not that it could not be applied to the arms, but all of our data sets and our studies show application on the legs only. That 1 liter of shift, or a little bit more than 1 liter of shift, typically gives us what we need to get the preload that we need. Makes the container smaller, increases the volume, so it achieves what we need without having to shift the about 200 that you would get from an extremity from an arm.
Gotcha.
Yeah, this definitely teachers need these in their classrooms. Unfortunate, but it would be a really great asset.
In schools,
for our
Yes,
students.
yes, of course.
All right. Anything else, guys?
Those are all my
I
questions.
think that's. Well, thank you very much for coming, and